be in the back of your head. It would help us a great deal in trying to sort out these issues. All right, now we turn to the state of Arkansas, the Antenatal and Neonatal Guidelines for Education and Learning Systems with Curtis Lowry and John Mesko. We thank both of you for being here. You must be Curtis.
Yes, sir.
All right.
Thank you. The single most important thing we do is reproduce. All living things are driven by this essential need. As a high-risk obstetrician at the state's only medical school, my entire focus is to aid humanity in this process. And ANGELS, Antenatal, Neonatal Guidelines Education and Learning System, is my answer to this call of duty. In a largely rural state with over 30,000 annual births, I am one of only 3 practicing certified maternal fetal medicine specialists in the entire state. In Arkansas, where health care resources are spread thin and needs are great, specialized health care is miles away from the population that needs it the very most. ANGELS is a unique partnership that links government to health care. This program was born from a collaboration between university physicians, rural primary care practitioners, the public health department, and Medicaid. Relying heavily on video conferencing technology and a 24-hour call center, the program is comprised of 3 core components: high-risk pregnancy consultations, maternal transport to tertiary care centers, and the development of obstetrical guidelines. Through these core components, specialists in Little Rock and providers in rural Arkansas can consult and manage high-risk pregnant patients without leaving their hometowns. ANGELS Telehealth Network is utilized for both consultative and education purposes. In 2006, ANGELS treated nearly 900 high-risk obstetrical patients in rural Arkansas through telemedicine and educated nearly 1,400 providers. Also in 2006, ANGELS facilitated 697 high-risk maternal transports to UAMS with another 100 to other regional tertiary care centers not at Little Rock. To add to these benefits, ANGELS shows distinct promises for Medicaid cost savings through improved maternal transport and regionalization of prenatal care throughout Arkansas. It is undeniable that ANGELS has impacted its target population. Arkansas witnessed a 25% increase in the proportion of extremely low birth weight infants from rural areas that delivered at UAMS after ANGELS implementation. This made possible a 7.8% reduction in infant mortality rate, and in just 4 short years of existence, ANGELS has assisted in reducing Arkansas's alarmingly high infant mortality rate. By affecting Arkansas, a state second poorest in women's health, 7th worst in poverty, and above the national low birth weight rate for 16 years, we can anticipate that ANGELS model can help any city, state, or nation in need. Combining technological innovation within a collaborative healthcare climate, ANGELS can be replicated anywhere. Healthcare programs and organizations in Louisiana, Florida, Wisconsin, and Illinois have expressed interest in the program, and the Hospital Corporation of America has visited Little Rock to study our successes. Even more impressive, ANGELS has been used as a model to replicate internationally, with the program striking close relationships with telehealth programs in Tübingen, Germany, Volgograd, Russia, and the nation of India. And recently, during a personal meeting with India's President Kalam, he expressed support for the duplication of ANGELS model in his nation. One of our keys to success is our relationship with practicing physicians. I would like to now introduce Dr. John Mesko, my virtual medical partner, an Arkansas obstetrician working closely with ANGELS since its inception, to give his viewpoint on the program's innovations and impact on his practice. John?
I am in solo private practice serving the rural town of Mena, Arkansas. I have found ANGELS to be extremely helpful to my patients in 2 major areas. The first is making it easier for my patients to get high-risk consultations, and the second is making it easier for me and local physicians to keep up with changes in health care. Our town of 6,000 people is very isolated, with the nearest interstate highway over 90 miles away. When my pregnant patients need high-risk consults, they face a 125-mile trek to Little Rock. To further complicate matters, 95% of our pregnant population are young, working-class families living below the poverty level. Many have only one vehicle already reserved for commuting to and from work. It is extremely helpful to our patients to get their consultations at the local hospital through the telemedicine link. Through ANGELS efforts, the numbers of patients receiving consultations has dramatically increased. This ensures more women are served for their high-risk pregnancy needs. Physicians' ability to obtain educational hours has also been dramatically improved. Through ANGELS, my personal CME hours have risen from the required 20 per year to around 70 per year. The increased knowledge gets incorporated into real-life policy changes 2 or 3 times per year. Smarter doctors equals better health care. Thank you.
Thank you very much. All right.
Good job, John.
Ed Dorn.
Dr. Lowry, did I understand you to say that you are one of only 3 physicians in the state specializing in?
Maternal fetal medicine, that's a subspecialty in obstetrics and gynecology designed to take care of sick mothers and sick
Gotcha.
fetuses.
Given that, have you thought about expanding this telemedicine effort across the region?
Yes, sir, it is. It's expanded across our region. We're doing across the border. You're talking about into other states or
Right,
within the state of Arkansas?
into other states, so that you expand the range of specialists.
Right. We're working with other groups within Memphis and some of the other surrounding states, Louisiana, to sort of copy the program in other places. So is that your question?
Yes.
Yes. And we've had people from Hospital Corporation of America, has 250 hospitals around the nation, in to visit to think about replicating the idea as well. So.
Bill Klinger. I'm sorry. Bill Klinger.
I understand that you are presently being evaluated by the University of North Carolina, or at least the program's being looked at and evaluated at this time. I'm sorry, in Arkansas?
No, sir. We have our own evaluation team. We have a health services researcher, a health economist, and we meet every week to evaluate the program, and we're publishing the data coming out of the system.
My other question really had to do with, it seems to me that the impetus, or the main proponents or people running the program are the university and the medical society. And what is the state's role precisely in terms of the program?
Well, Medicaid saw the high perinatal mortality rate and asked us to begin to affect this with regionalization of perinatal care. And so this program is an effective methodology to try to assure that sick mothers deliver at tertiary care centers with sick babies, because that's one thing you can say beyond a scientific doubt, that you can improve perinatal mortality is by accomplishing this task. We haven't done very well with reducing the incidence of preterm birth, but if you assure that the premature infant delivers at a tertiary care center, you do impact morbidity and mortality.
So could you say a little about what outcome data you have just as a follow-up to Bill's question? You have these people who are looking at the outcomes. What are you learning
Yes.
week by week, month by month?
Well, we have, we're linking the Medicaid claims data to the birth certificates, to the hospital discharge summaries, to the data we have in Angels. And we've shown that we've had an impact on the very low birth weight incidence. We've shown that we've reduced death rate by about 30 to 40 babies per year as a result of this by the very premature infants. And we've also begun to look at mortality rates in the state, and surprisingly enough, which we'll be publishing in the next 2 years, we have found that some of the higher rates that Arkansas experiences is in actually the higher birth weight infants, the near preterm, higher birth weight infants, which will result in a complete refocusing of Medicaid and health care services to begin to explore what we can do about these larger weight infants and not so much the small ones.
I'm a little uncertain yet about, because there's some, the site evaluation was not as precise as you are, but how much real progress you've been able to measure so far, the real impact.
Right. Well, clearly we've increased the number of transports to the tertiary care center, and we've reduced the infant mortality. Yes, sir?
Can you give us some sense of that?
Well, 670, 25% increase in the number of patients that are delivering infants, 25% increase. So that translates to around, in real terms, we've got around 300 more transports per year to the university than occurred prior to this. And not all those are premature infants, but there's a significant portion, at least 30% of those are premature infants, deliver premature infants.
Is there any evidence, or is this way too early, to improve the state's overall standing in terms of women's health? Arkansas has long been plagued by this, by the fact that it's ranked very low. Some would say second from the bottom in terms of the United States.
Right, and I think that's true. Unfortunately, I think we always look to health care for these answers, and I think many of these answers are social, economic issues. And I think it's unrealistic to think that health care is going to fix these things. We're trying to focus on the things that we can fix, which is that mothers should be transferred to tertiary care centers to deliver their premature infants. And if we can accomplish that and also take care of the mothers with medical problems, we can impact this aspect.
The primary innovator here was you.
Yes.
You seem to be the driving force behind this program.
Yes, it's simply put about connections, right? Making connections between practicing physicians and hospitals in the rural areas.
But you did this not you did this at the University of Arkansas in the medical school.
Yes, I'm a professor at the university.
All right. Well, we congratulate you both on what you're doing. Thank you very much.
Thank you, sir.
Ladies and gentlemen, that completes the first third of these the testimonies today. We are scheduled for a 10-minute break. I would point